It's so great to be here. I love coming to this meeting because it's so filled with passion, and everyone in this room is really committed to the cause of advancing the therapies that we have, the way we manage patients, the science and our understanding of these tumors. So thank you for the privilege of opening up this session. My work here is really to just lay the groundwork so that we all get on the same page about what is a desmoid tumor, how are they generally managed, and then we'll get into a little bit about spontaneous regression. All right, so what is a desmoid tumor? So these are rare, locally aggressive tumors made of fibroblasts. That is a short phrase with a lot of terminology, so let's break it down one by one. So a tumor is a very generic term. It doesn't imply that it's a cancer or that it has any potential to cause issues. It's simply a growth or a lump or a mass. In the case of desmoid tumors, these are composed primarily of fibroblasts, and fibroblasts are a type of cell in the body that gives structures to certain organs, and they're also one of the key players in responding to injury. So, for example, in the case of a surgery or a trauma or some injury, that's the first cell type that comes in and helps clean everything up and get the wound healed. They also are part of scar tissue formation too. So these are the cells that kind of go awry in the case of desmoid tumors and grow into that lump, mass, etc. These are rare tumors, as I'm sure everyone in this audience knows. It's just 5 to 6 cases per 1 million people. And that amounts to about 1,000 to 1,500 patients in the U.S. diagnosed each year. So just to put it in perspective, for example, compared to some common cancers, breast cancer, prostate cancer, hundreds of thousands of patients have those types of cancers. This tumor is relatively very rare, and anything less than 20,000 cases per year is considered to be a rare disease. So this is certainly falling in that category. So I want to break down this term locally aggressive. So what we use when we're diagnosing a tumor and understanding what it is, we put it into 4 general categories based on our book that kind of helps us to diagnose diseases in soft tissue and bone tumors. The 4 general categories in this book are malignant, intermediate, and there's 2 different categories there. One is rarely metastasizing, one is locally aggressive, and then benign tumors. So starting from the bottom of that list, benign just means that that lump is not causing any issues, it's not causing any pain, it's not causing any complications, and it can't spread to another part of the body. So benign, an example of that would be like a lipoma, a fatty tumor that really doesn't do anything, may slowly grow over time, but is not causing any symptoms. I know a lot of people that come to our offices have heard that maybe their tumor that was a desmoid tumor early on was thought to be a lipoma. That's a very common type of tumor in the body, so that's why I think that is often, the desmoid tumors can often be mislabeled as those events in the early days when they're still being worked up. The next category, intermediate. So these types of tumors, the locally aggressive ones means that they can kind of invade into nearby structures. They can cause dysfunction to surrounding organs. They cause pain. They can affect function. They can regrow more readily after a surgical procedure. Sometimes they can even cause rare or life-threatening complications. But they generally don't metastasize. They can be, in the case of desmoid tumors, multifocal, meaning they can be in many places within one person, but they're all distinct tumors. It's not like one tumor spread to those other areas. It's just that some patients, usually ones with underlying genetic conditions, can have the desmoid tumor form in multiple parts of the body. Intermediate, rarely metastasizing just means that it's a tumor that is very unlikely to spread versus malignant, which is a cancer. What gives cancer the distinction from these other ones is that cancers can spread to other parts of the body, but that's really the only distinction. So it's all semantics, right? But I think one thing that comes up a lot for patients with desmoid tumors is They are really impacted by their disease. They're seeing us in a cancer center. They're undergoing treatments that are often used for cancers, but it's not technically termed a cancer. In my opinion, that's just semantics, but I wanted to give a little bit more nuance to this term, locally aggressive, and how that's distinguished from malignancies, because I know that comes up a lot. All right, so where do desmoid tumors form? They really can form anywhere in the body. Some of the most common places are the extremities, the muscles of the abdominal wall, the mesentery, which is the tissue that surrounds the digestive organs in the abdomen, the trunk, and the head and neck area. Desmoid tumors can form randomly, or they can be associated with an inherited condition. When they form without an inherited condition in the background, usually we can detect a genetic mutation in beta-catenin, and the gene that encodes beta-catenin is called CTNNB1. FAP, or familial adenomatous polyposis, is a genetic condition. It's typically inherited through inherited genetics, and there's a family history that would go along with that. These patients have a lot of colon polyps, typically earlier in their even teens and 20s, and then by the age 40 often have colon cancer. So that's the condition FAP. That's about 5 to 10% of the patients that have desmoid tumors will also have that condition. At the end of the day, both of these genetic changes, either CTNNB1 mutation or the APC gene mutation, the end result is that the tumor cells have increased growth signals, and that causes them to form this tumor and keep growing. Some of them can spontaneously regress, about 25%. Some may grow for a bit and then stabilize and just stay at that level, at that size. Others may continue to grow, and then some may regress after growing. So about a third, where after diagnosis we see that there's this growth, about a third may regress later. So the workup of a desmoid tumor, there's usually initial imaging to better define the mass or the lump that's discovered, and then that often leads to more imaging to help us, distinguish what type of mass it is and what are its features. So that could be CT scan, MRI. Sometimes we see PET scans are done. Those are usually not very informative for desmoid tumors, but could be informative for other types of masses in the body. So sometimes that's done as part of the patient's initial workup. Then that typically leads to a biopsy. The thing on the biopsy that we look for to diagnose a desmoid tumor, other than the shape and the general characteristics and what the cells look like, is that we can see beta-catenin staining in the tumor cells. And I want to make a point that beta-catenin staining in the tumor cells doesn't mean that there's a beta-catenin mutation present, which can, I think, confuse a lot. If you had an APC mutated tumor in someone with FAP, for example, that tumor could also have beta-catenin positive in the nucleus. So that, and I'm saying all this just to make it clear that just because there's beta-catenin staining doesn't mean that there's not an underlying genetic predisposition, and it's still a good idea to talk to a genetics counselor about if there's potentially some sort of underlying inherited condition at play. And then I think consultation usually follows that. Usually once there's a diagnosis made, a patient may see a medical oncologist. Ideally a specialist at this point that specializes in the care of desmoid tumors. But if that's not the case, then referral for a second opinion I think is a really good idea, especially as the initial management plan is coming together. And just a quick plug for second opinions, don't feel bad. These are very common in medicine. Your doctor should understand, and sometimes if it's a rare disease or something, for example, in my practice that I'm not used to managing, I will offer a referral. So that's something that you shouldn't feel awkward about, but I know it can be a little bit awkward if you're the one that's bringing it up. So I suggest saying, hey, this is a rare type of tumor, I'd like to get a second opinion. That should be all you have to say, and then you can seek out another opinion from there. Because I think deciding when and how to treat desmoid tumors is becoming more and more complicated over time as we get more medications that we're using and more modalities, like the interventional ones that we'll hear about a little bit later, like ablation and things like that, it's becoming more complicated, and it's good to see a specialist that sees these tumors regularly. And just because you're seeing a specialist doesn't mean that you're seeing them forever. It could just be a check-in every once in a while. They can partner with your local doctor to help guide them on how to manage it. So it doesn't have to be like you're changing care, especially if it's not like you have a sarcoma center in your backyard that you can easily access. And then this may also open up the options for clinical trials. So a lot of the research will most likely be done at an institution that cares for desmoid patients more regularly. So just by seeing that specialist, you may hear about other trials and things that would otherwise not be available through a local group. All right, key management options. We're usually thinking if we see that patient initially, we're talking about active surveillance and weighing that against actively treating the tumor with medical therapies, and these could be things like chemotherapies, small molecule inhibitors like gamma secretase inhibitors, and then tyrosine kinase inhibitors, a lot of different categories or trials. Ablation techniques are another thing that we're often considering earlier on in management. Surgery and radiation I put here, but they're usually reserved for later in the treatment course. But these are really highly nuanced situations, really individualized to the patient-specific situation. So these are like the broad categories, but choosing how to start is really a good idea to discuss individually with your team. But just to speak broadly about that, how do you know when it's safe to monitor versus start treatment? So we're typically weighing risks and benefits when we're making this decision in clinic. It depends on the one hand, is the tumor in a critical location? Is it going to cause symptoms, or is it already causing symptoms? And are there any complications that could come up? That might make us favor starting treatment sooner than later. But then we also have to weigh that against the side effects, the medical bills, the time it takes to come to a treatment center, to undergo all the monitoring needed during treatments, et cetera, and how that fits in with the patient's life. So these are really complicated decisions, and I think one thing that's challenging is that we really don't have a good biomarker to predict desmoid tumor behavior. So when we're seeing a patient at the first visit, it's hard to know whether this tumor is going to grow or regress or act in a way that causes more complications. So this is a big drive in desmoid research, is trying to understand how we can better predict the behavior of these tumors. So some exploratory things that the community is working on are looking at MRI features. We talked a lot about this yesterday in our research meeting. There are certain MRI features that may predict whether the tumor will grow or whether it's more in a regressive or stable phase. There are also some groups looking at circulating tumor DNA, and what that is the tumor cells actually release little fragments of their DNA into the bloodstream so that beta-catenin mutation or APC mutation could be picked up in the bloodstream. Actually, APC would be more challenging in an individual that has a germline or an inherited APC mutation, because then they would be in all of their cells, and we couldn't really distinguish the desmoid tumor from the background of the person's genetics. But in the case of a beta-catenin mutation, that would be more feasible. So these are some things that we're looking at to understand the desmoid tumor activity. And then last is the tumor genetic testing. So some groups are looking at whether specific CTNNB1 mutations have a higher chance of progressing or regressing. And maybe someday we have a way to combine all of these to really understand what the desmoid tumor behavior will be. But one thing that I've been working on with my collaborators that I've listed here at the bottom of the slide is trying to understand more about the tumors that we have banked. So we've been banking samples at Dana-Farber since 2005. We have over 70 desmoid tumors that we have at the frozen in the frozen bank, and we can run genetic testing on these tumors to look for DNA changes like the ones I mentioned, beta-catenin, APC, and others outside of that. And then we also test for RNA differences. And that gives us information on what are the cells producing, what pathways are some dependent on that others may not be, or that some are really upregulated that others may be suppressing, and does that relate in any way to how the tumor is behaving? So this is something that we're actively analyzing now. And one of the things that we think will be really informative is we've taken a small subset of the 70 tumors, and we've looked at 12 initially, and really gone into detail looking at individual cells within the tumor to understand the things that are being produced and the signaling pathways that are active in individual cells within the tumor. And just to say, not all cells within a tumor are those desmoid tumors, or those desmoid tumor cells. Some of them could be immune cells, some of them could be blood vessel cells, some could be other fibroblasts that aren't desmoid tumor cells, but that are just part of the natural support structure that the body has. So we're parsing out all these individual components in the tumor and understanding what factors they're making, and we hope that that gives us a lot of insight into how the tumors behave, how these different cells in the tumor interact with each other, how they're supporting each other, and then therefore how we can intervene. And we hope that this gives us a lot of insight into how to improve on our treatments and how to develop new biomarkers for this disease. And Dr. Al-Jazwari, who's sitting in the back, has done a lot of work, and it's supported by the DTRF to help us really identify which cells are tumor cells and which cells are the other cells present in the tumor microenvironment. So this is exciting work that's ongoing, but a really big interest in the DTRF and in the research community. So I just wanted to touch on this today. So that's it. I know that was a whirlwind, so please ask any questions that you have. I'm happy to break it down and explain a little bit better in the Q&A session. Thank you. As Lynn mentioned, if you have a question, come up to the microphone. I'll also be at the lunch later if you want to pull me aside. Mm-hmm. Good question. I'll repeat it since we didn't have the microphone set up yet. So the question was whether in the study that we're looking at to help better understand desmoid tumor behavior, if we're collecting from different areas of the body and if that gives us any information about the behavior. And that's something that we're absolutely going to look at. We have a variety of tumors from the head and neck area, the mesentery, the abdominal wall, the pelvis, the extremities. We have pediatric cases, we have adult cases, we have some cases associated with pregnancy, others where there was no pregnancy around the time of the diagnosis. So we have a really good variety, and all of those questions about what clues can we get from this data set, what comparisons can we make, we'll absolutely be looking at the site of the disease, the patient-specific factors and all of that to try and understand.
Hi. You mentioned that 33% of the tumors will spontaneously regress. When my daughter was first diagnosed, we were told maybe 5 years it'll burn itself out. Well, that was a long time ago. So of the sort of 70% that's remaining, how long? Is this a lifelong issue that people are dealing with? So in 20, 30 years, what are you seeing?
That's a great question. So there was recently a publication looking at 3 big natural history studies that took place in Europe and combined all those data and followed those patients over years. So we saw that 25%, the initial thing that happened to that tumor was spontaneous regression. And then there was a variety that were maybe more slowly growing, and then some that grew to a larger extent and then later regressed. So we saw that of the cases that were growing, about a third of those regressed spontaneously. We think that the ones that regress spontaneously could be a more stable situation, like that maybe if there's spontaneous regression, the tumor kind of backs down on its own, that it's more likely to stay that way. These are big questions that we're all interested in getting more data about. So the DTRF has a patient registry. I really encourage everyone to put data in there because we'll be looking at exactly those questions. One thing that we heard yesterday from our patients that joined us yesterday was that fear of this thing coming back is a big issue. So we want to get as much information as we can to study them, because for the ones that need treatment, there can be continued growth or there can be a stabilization period and then regrowth later after treatment. So these are all really important details for us to understand to help reassure our patients or let them know what to expect. Does that answer your question a little bit? Okay. Yep.
Mine's just a follow-up. So how do you tease out then, like in your trials, even for the patients that are on medications, when it's spontaneous regression versus the effect of the drug?
Great question. Right now, the way that desmoid tumor trials have been designed in the more contemporary era is to have a control group with a placebo arm, which is not ideal, right? But that's the only way that we can control for that issue of spontaneous regression. And you'll see in the big trials that have been done, nirogacestat, sorafenib, you'll see in the placebo group that there still are some that are regressing. Also, for the more recent studies, it's a requirement that the tumor is progressing at the time of entry, at least growing to a certain extent. And we still, as I mentioned, still see this phenomenon where there can be regression after that. So at this moment, that's how it's been addressed. But we all recognize that that's not ideal, and that's why collecting this natural history information helps us to think of other ways to design our trials better so that all patients that are participating can have access to that treatment.